tracheal access geometry in the laryngoscope era. Before we get started, I would like to go over a few items so you know how to participate in today's event. You've joined the presentation listening through your computer's speaker system by default. To make adjustments to your audio, click the settings wheel at the top of the GoToWebinar window. Throughout the presentation, you can submit questions for our speakers by typing them into the questions panel. To access this panel, click the questions icon at the top right. We will address the questions during the Q&A portion at the end. You may also enable closed captioning for this presentation by clicking the CC icon located towards the bottom right of the window. I would now like to introduce Jamie Monroe of Pentland Medical. Jamie?
Thanks, Wendy, and good evening, everyone, and thanks for joining our webinar, Tracheal Access Geometry in the Video Laryngoscope Era. I'm Jamie Monroe. I'm one of the directors at Pentland Medical, and Pentland Medical have over 25 years experience working with innovative, unique and patented solutions, focusing mainly in anaesthesia and operating theatres. One such device, one of our new products, is the Total Control Introducer, and we will be discussing this later in the webinar. But just to go over the agenda very quickly, I will very shortly be handing over to Dr. Sean Runnels, who will be discussing modern intubation theory, airway geometry, and tracheal access problems in the video laryngoscope era. I'll then take back over as we move from theory to practice, and I'll go into the Total Control Introducer in a bit more detail. And at the end of today's session, we have a live Q&A, so please do submit your questions throughout today's webinar, and Sean and I will do our best to answer as many as possible at the end. So without further ado, I'd like to hand over to Dr. Sean Runnels. Sean is the inventor of the Total Control Introducer, the CEO of Through the Cords, and an associate professor of anesthesiology at the University of Utah. So Sean, over to you.
Okay, thank you, Jamie. As Jamie said, I'm an erstwhile inventor and run the company Through the Cords. I'm also an associate professor at the University of Utah. What I'm going to talk to you about today is the geometry and kind of some modern intubation theory that helps us understand the shifts that are happening as we move from the direct laryngoscopy era to the video laryngoscopy era. So first thing to understand is the shift from DL to VL is changing the theory and the models of intubation that we need to use to successfully intubate people. So the age of VL is here. We are quickly experiencing VL as becoming the standard of care. The DAS guidelines in the last year are evidence of that. And VL adoption has crossed a tipping point. So we are heading there, whether we want to go there or not, or whether you want to go there or not, we're definitely moving in that direction. This means that we have to change our understandings of airway geometry. VL does not change the natural serpentine geometry of the airway. We're going to talk about that and dig into that. The tube must now traverse a serpentine pathway when a hyperangulated video laryngoscope blade is used, as well as a standard geometry video laryngoscope blade, and we'll dig into that as well. There's a new failure mode. The DL era was characterized by visualization problems, and the VL era is characterized by tracheal access problems. So intubation is shifting from can't see to can't deliver the tube. So there's new solutions out there. We'll talk about that today. And obviously one of the devices I'm bringing to market is a dynamic tracheal access tool. I invented it, so I'm certainly biased. Anything I say about it, you can take with a grain of salt. If I say anything negative about it, you can take that to the bank. I will stick to published literature, and all the publications will be available at the end of the webinar for you to download. So dynamic tracheal access offers precision tracheal access And it allows us to personalize the tracheal access tool to an individual's airway geometry. So part one, the age of VL is here. The video laryngoscope is no longer just an alternative or a toy. It's quickly becoming standard of care. This is an AMBU Market Day report, and this is the video laryngoscopy adoption curve, and we have crossed a tipping point. Video laryngoscopes were introduced into the market in 2006. We're now about 50% of intubations done worldwide are done with a video laryngoscope. In 2028 and 2029, 75% will be done if we stay on this curve, and I don't see any reason that we won't stay on this curve. And that's an important number, but we'll discuss why a little bit later. So personally, I gained some insight and started really thinking about difficult airways. I spent 3 years in Africa, 1 year working for Mercy Ships in Guinea, and 2 more in Rwanda. In Rwanda, what I saw was that all of our airway disasters had the same pattern. We used direct laryngoscopes because that's the majority of what we had as far as laryngoscopes. We did have video laryngoscopes. They were in short supply, so they were not immediately available. And what we saw was failed visualization with DL, followed by failed video laryngoscopy with an adequate view, but failed ET tube delivery. What about fiber optic bronchoscopes? We did not have working fiber optic bronchoscopes in Rwanda. On Mercy Ships, what I saw was the providers that were visiting, I was there for a year, and the providers visiting had limited fiber optic bronch skill sets. And that's a common problem with fiber optic bronchoscopes. And we ended up with a lot of fiber optic flogs.
We do not have a functioning display to perform an intubation with the fiber optic scope alone. None of this equipment is regularly available at this hospital. You can see that the tumor is filling her right lower jaw on the floor.
I see what's happening. Sorry. I'm a little confused there. So this is a video, and I'll turn off the sound. This is a patient up in the corner here that has an ameloblastoma, and those were very difficult cases in Rwanda. What we did on Mercy Ships and in Rwanda was we would put these patients to sleep, make sure we could ventilate them, and then we'd use a video laryngoscope for visualization. And this one's in Rwanda. Dr. Christian is one of the faculty that I was working with. And we could almost always visualize with a video laryngoscope if they could open their mouth. Tracheal access was the issue. We did have ambuscopes that a donor had given us. However, they did not donate the screen, God bless their soul. And so we used the ambuscope simply as dynamic introducers. And what I quickly found was I could have somebody see one, I could teach them, they could do one with me, and then they were off to the races and were able to manage these very complex airways really very safely and quickly. It was a very efficient way to intubate. And that's where I started to think about, why don't we have a purpose-built dynamic access tool? And that's when I started this project. So, austerity made VL and fiber optic bronch limitations impossible to ignore. So the natural airway geometry is serpentine. Ken Greenland published this in 2008. And, the traditional model is alignment of 3 axes. That was invented in 1944 by Bannister, and it was really invented to explain how a direct laryngoscope works. It really is an irrelevant, but historically important geometric model in the video laryngoscopy age. So the better model that's out there now is that the airway has a primary curve in the anterior direction, an inflection point at the glottis, and then a secondary curve at the glottis that that heads back down the trachea. And so in summary, it's two curves, opposite directions, and there's an inflection point at the glottis. And this is essentially serpentine geometry. So intubation is, of course, always a two-step procedure. We need to be able to visualize or view the cords, and then we need to be able to place the endotracheal tube, tracheal access. First pass success requires both of those to take place. The DL era was organized around improving the view, so techniques and technology that improve visualization. And the tracheal access era will be organized around techniques and technology that improve tracheal access. I think of intubation as being accomplished with a system of three interdependent components. There's always an operator. There can be two operators in a double operator system. Visualization equipment and tracheal access equipment. And when all of these, important concept here is when all of these components are in harmony, we get good outcomes. If we have the best visualization equipment, which is hands down a video laryngoscope, and we have great tracheal access equipment in the form of dynamic access, but a medical student at the helm, that medical student's skills and knowledge is going to be the rate limiting part of that system. So each component enables and limits the other components, and success or failure of any attempt depends on the weakest part of those components. So VL improves visualization without changing or necessarily changing the natural serpentine geometry of the airway. So when we used a direct laryngoscope, we used it essentially as a retractor with a light on the end. We place it in the mouth and we force the primary curve flat, and that changes the airway into linear geometry. And so tracheal access is linear. When you're using a direct laryngoscope, a bougie is your best friend. There is no question about that. When you're using a video laryngoscope, we can now look around the corner and visualize the glottis. Now, the important thing there is the natural serpentine geometry remains unchanged. And so there is not necessarily a geometry change. And that means we now have to access the trachea through serpentine geometry. So the key point here is the blade geometry determines tracheal access geometry. If we're using a direct laryngoscope, standard geometry blade, tracheal access is essentially linear. If we're using a video laryngoscope with a standard geometry blade, we don't have to quite make it linear. We can, but often what we end up with is semi-serpentine, and bougies actually work very well with a standard VL blade. But we give up the ability to see that 3 to 4 to 5% of people who have an anteriorly placed vocal cords. And so we're going to struggle with them. So then we end up with a hyperangulated VL blade. And now we really, it's about 1 in 1,000 patients that we can't get an adequate view with a hyperangulated blade. But we are working now with fully serpentine geometry, and tracheal access can be a problem. So the geometry lesson for the VL area is, the key point is visualization approach determines the tracheal access geometry. So when we're working through tracheal access geometry that's serpentine, we have to solve a 3-part geometry problem. When we're using standard equipment, which is static, it's really only aimed at solving the anterior curve. And so what we see is we're really, when we bend our stylets or we use a rigid stylet, it is set to match that static anterior curve of the primary curve of the airway. So it only solves the primary curve. The secondary curve and the inflection point are solved by force. Those are not solved by the stylet. In fact, you have to remove the stylet to actually have the endotracheal tube go through the inflection point at the glottis and then back down the other side. And we're going to dig into that. So the inflection point and secondary curve are solved by force on the anterior trachea and force on tissue. Okay, the endotracheal tube is driven into the anterior trachea, and that impact creates the force necessary to bend that tip of the tracheal access equipment, in this case, the endotracheal tube, back down into that serpentine shape. Okay, successful tracheal access with static equipment requires collision with the anterior structures of the trachea, period. So this is a cadaver study. We presented this at the World Airway Management Conference in 2025. And what we did was we took a cadaver and we placed a bronchoscope at the carina, and we watched endotracheal tubes come in below the vocal cords. And we think this is some of the first footage ever of intubations from below the vocal cords. So in this case, this is a hyperangulated blade, so great view, and a rigid glide right stylet. And what you can see is the force on the anterior trachea as that tube comes off the stylet. And now the stylet's going to be removed. And then you can watch what happens to that tip as you go down, get it in. And it's generating the force through collision to coerce the tip back down into the posterior configuration and bend the tube into a serpentine shape. Okay, and this actually has real-world consequences, which we're starting to see published now. This is a tracheal perforation following intubation with a double lumen tube and a hyperangulated blade, and this was published in Anesthesia. So we are starting to see evidence that force below the trachea can be harmful. Of course, double lumen tubes are very stiff and bulky, and so you can imagine the force necessary to coerce that tip back down the trachea is high. So as we transition from the DL era to the VL era, shifts in primary intubation failure mode are happening. So now we are moving from I can't see to I can see the cords, but I can't deliver the endotracheal tube. And that's a tracheal access issue. So the intubation failure mode is shifting, DL era, primary failure mode, visualization failure. DL intubation success was tightly coupled to visualization. The better the CL view, the better the outcomes. And that was proven over and over. If you can get to a grade 1 view, you're going to have a higher success rate and less trauma for the patient. So in the VL era, the primary failure mode is shifted. It's now tracheal access failure. And interestingly, visualization success is now uncoupled from intubation success. We know that if you have a grade 1 view with a hyperangulated blade, you actually have lower intubation success. And once you understand the geometry, that makes sense. So we're searching currently for what is the new theory that is going to drive success and improvement in the VL era. So these are some studies that demonstrate empirically the intubation failure, shifting intubation failure mode. So this is a big study by Krieg, and I'm sure most of you are aware of this. They looked at operating room intubations with video laryngoscopes and direct laryngoscopes. They were all seasoned operators, multi-centered, randomized controlled trial with observational data. So the best stuff we can get. And what they saw was first pass rates, video laryngoscope, 94%, direct laryngoscope, 82%. Interestingly, they asked when you failed with a first pass attempt, why did you fail? And in the secondary data, we can see with direct laryngoscopy, visualization failure made up 84% of the failures. With video laryngoscopy, 86% of the failures were tracheal access failures. So you can see the shift. Essentially the same study was done in the ED and the ICU, so critically ill patients by Precker. First pass success, video laryngoscopy 85.1%, direct laryngoscopy 70.8%. And again, failure mode, direct laryngoscopy, 71% of the failures were visualization failures. Video laryngoscopy, 66%. So again, you can see that shift taking place as we shift eras. This is a study that was an oral presentation at the World Airway Management meeting in Florence, and it's BJA abstract pending currently. And what this is a calculator, and it allows you to see what's happening on the bottom. This is 10% VL adoption, 20%, 30%, 40%, up to the world of the future, where we're only using video laryngoscopy. And the data from Krieg and Precker were put into this, and so you can scale up to 50 million intubations per year. And what we do see is as VL adoption goes up, the total first pass failures fall. Visualization falls quite steeply, visualization failures, which is to be expected. But you can see here that we actually increase in the absolute numbers of tracheal access failure. And so what we can see is there's a crossover point when tracheal access eclipses visualization as the dominant cause of first pass intubation failure, and that's at 75% VL use. So this was part of the same oral presentation. This is back to our adaptation curve. We're at 50% now. 75% comes in 2028, 2029. So we have the privilege of seeing the problem, the main problem of the future, and we have some time to prepare for that. With equipment, we need a tracheal access classification system that's analogous to the Cormack-Lahaney system, so that we can start to study tracheal access in an organized fashion. We also need a new theory that is not coupled to visualization to understand how we can improve. So tracheal access eclipses visualization failure as the main intubation failure mode, and that's expected to happen in 2028, 2029. So first pass failure carries a cost in both lives and dollars. We now know that there's an increase in 28-day ICU mortality with major adverse peri-intubation attempts. That was published by Risotto, and he also linked first pass failure to that increase in major mortality. And what he saw was a 14% increase in 28-day mortality with each attempt, or when there's a major event that are caused by first pass failure. And so first pass failure increases the rate of major adverse events and increases mortality. Expected excess deaths associated with continued use of direct laryngoscopy in the critically ill patients in the United States, and we do about somewhere between 5 and 8 million intubations in critically ill patients in the United States. When you calculate or extrapolate that out with Pecker's or with Risotto's data, you end up with about 39,000 preventable deaths. And people are surprised at this, but one of the things that we see is we have a hard time scaling our personal practice up to a national practice or an international practice. In the operating rooms, there's an expected, if we continue to use, if we get to 100% VL in our operating rooms in the United States, that's expected to save about $3.9 billion in costs. This is a link to our intubation calculator. So you can go into the calculator, it has references in it, and play around in that and see what this means in your personal practice or in your group practice, or even at the level of a trust or the UK in general. And that link will be on the last slide as well. So if you don't get a chance to scan it here, you can scan it at the end. So how do we classify tracheal access equipment? There's 3 necessary geometric configurations to reach the mid-trachea when you are using tracheal access equipment with a hyperangulated blade or need to traverse serpentine geometry. So primary curve, the orientation of the shaft needs to be anterior, and the tip of the equipment is also anteriorly oriented. And so that's our static introducers, malleable bougies, where we're really putting that primary curve. They're set with a primary curve. The second configuration is we need to be able to move through that inflection point. In that case, the shaft is still oriented in an anterior direction, but now the tip needs to move in a posterior direction. And then the third configuration is when we, in order to get through to the secondary curve, the shaft now needs to assume a serpentine geometry. And so it needs to be shaped in parts of it in an anterior direction, and another part in a posterior direction, and the tip needs to be in a posterior direction. So in order to flow through a serpentine pathology, you can think of a snake. A snake can do that. It has a cervical spine that moves up and down, and a thoracic spine and a lumbar spine that are flexible. And that allows for snakes to move through serpentine geometry without problems. So what does that mean for force? So static equipment, anterior curve preset. These are malleable bougies, rigid stylets, malleable stylets. They have a fixed anterior curve. They can solve, think of a snake with a fully fused spine. It can actively solve the primary curve only, but you're going to have to really stuff it through the inflection point and then break its back to get it to move through the secondary curve. And so the force, and that is done with collision with tissue, and that's what provides the coercive force to move through that serpentine pathway. Then we have semi-dynamic equipment. There's been multiple stylets that have fixed anterior curves, and they have articulating tips. So a fixed anterior curve, or a set anterior curve, and an articulating tip, and those can solve this is a snake with a mobile cervical spine and a mobile thoracic spine, but a fused lumbar spine. And so they can solve the primary curve and the inflection point actively, but they require collision to coerce the shaft into a serpentine pattern. Now, dynamic introducers, which have articulating tips, they can change the they can dynamically change the anterior curve, and they have flexible shafts. That's like a snake with a fully mobile spine. So the head can move up and down, and then the body is supple, so it can easily flow through the the inflection point and the secondary curve. And a fiber optic bronchoscope can do this as well. That's a fully dynamic piece of equipment. So we need coercive force to reconfigure our equipment so that we can move through the primary curve, the inflection point, and the secondary point. One of the critical questions is, how do we generate that force? Is it via collision with patient's tissue or by the operator's hand? And so for static equipment, primary curve, the device rigidity And preset shape is how the primary curve is, the force is transmitted to the endotracheal tube to hold that shape. The inflection point, collision with the anterior structures of the trachea and the glottis. And the secondary curve, again, we need to be able to move, to bend that snake's back so that it can form that serpentine pathway. And that is, again, done with coercive force from tissue collision. Semi-dynamic equipment, the primary curve, device rigidity and preset shape. Inflection point, operator's hand that articulates the tip. And then the secondary curve, again, collision with tissue. Fully dynamic equipment, operator's hand can set the anterior shape of the anterior curve. And inflection point is, again, force from the operator's hand. And secondary curve is via the operator's hand. So what does that look like? This is a cutaway, and you can see the serpentine nature. This is what we're working with, and I'm going to play this video and talk a little bit as we do. So you can see snake's head goes up and down, really no force necessary or very little, and then the tube follows, and the catheter actually carries the force and reshapes the endotracheal tube. So not much force on tissue necessary. And so snake-like capabilities are necessary for force-free or low-force intubations when we're using hyperangulated video laryngoscopes. Fully articulating tips, flexible non-biased shafts, and force is generated by the hand of the operator, not the tissue of the patient. Okay, so let's see what that looks like. And again, this was presented at WAM. This is the same cadaver setup, but this time we're going to watch a dynamic introducer. So the first view, oh, sorry, it stopped. I'm going to try to play it one more time. Okay, and I'm not going to touch it. I think there's a click lag and I keep turning it off. So it needs to move through a serpentine geometry. This is a hyperangulated video laryngoscope blade with a steerable introducer. So great view. Think of it like a snake. The head comes up, solves the inflection point. So you can see the anterior structures of the trachea and the glottis are undisturbed. And then when the endotracheal tube comes in, the force necessary to coerce the endotracheal tube into that serpentine geometry are provided by the catheter, not the patient. Okay, this is a study in mannequins made with a difficult airway, or made to have difficult airways, that was performed by Dylan in the UK. Many of you would be familiar with this study. And what they did was they compared different tracheal access equipment with difficult airways. And the way they made the airway difficult was they used a mannequin where you could actually make the glottis anterior. And so they compared C-max stylettes with dynamic introducers in the embodiment of the TCI. In the US, this is called the Runnels steerable introducer. A USB, which is essentially a malleable stylet or introducer. The STIG, which would be a semi-dynamic, has that preset curve, but the tip will move, and then a Portex bougie. And in the difficult airway setup, you can see that the best performers were the C-Max stylet and the dynamic introducer. And when you take into account the error bars there, or the confidence bars, there's a very little statistical difference between the two. And then the USB and the STIG and the Portex have falling off success with that. Now, the important thing to remember is this is a mannequin study. Mannequins don't complain about sore throats afterwards. And so these are force insensitive models. Humans, we don't know this for sure, but humans are probably feel a little more free to apply excessive force to mannequins. So this study is actually going to be repeated with a mannequin that has force sensors, and we'll find out what it looks like when you add force into the equation. So difficult airways is a subgroup analysis between the TCI and the STIG. First attempt success, 87% with the TCI, 60% with the STIG. Intubation within 120 seconds, 93% with the TCI, 70% with the STIG, and median time to intubate, 36 seconds, 45 seconds with the STIG. So now this is, Mazanari did a study with static stylets in the form of a glide right stylet, a rigid stylet, hyperangulated blades, and dynamic introducers. And in this case, the dynamic introducer was an ambuscope, and they did not hook the visualization capabilities of the ambuscope up. So it was simply a blind dynamic introducer. All of the visualization came from the hyperangulated video laryngoscope blade. And what he saw was superior results with dynamic introducers. These were known difficult airways. First pass success with a dynamic introducer, 91%, 67% with static introducers. And importantly, trauma dropped tenfold, 11% with static introducers and 1% with dynamic introducers. And now that I think you understand why trauma might drop when you're using a dynamic introducer, because the force necessary to move through that serpentine pathway is less. So what about when you fail with a rigid stylet in a video laryngoscope? So this is a case series, a consecutive case series published in ANA Practice. And what it says is dynamic access can rescue after that kind of failure. So overall, video laryngoscopy plus a dynamic introducer, rescue success, 33 out of 34 cases, 97% rescue rate. 94 of those happened on the first attempt. So what we're bringing to market and what we're introducing into our intubation ecosystem is a best-in-class intubation system. Video laryngoscopy is absolutely hands down the best way to visualize the glottis. Precker and Krieg were really nails in the coffin of the video laryngoscope. The coffin has been lowered into the grave, and dirt is currently being thrown on it. So we are well into the DL era. And dynamic tracheal access is evidence-based, the best way to move through a serpentine pathway with a hyperangulated blade. And what this does is it allows, for the first time, precision tracheal access. And this allows us to personalize the geometry of our intubation tools to the geometry of the individual patient. Rigid stylets work on about 96% of the patients, and then we're starting to force the patient's geometry to match the shape of our rigid stylet. This is an awake intubation to kind of walk you through how the device works. This patient has neck radiation. He's been intubated a few times and is known to be difficult. Gets awake fiber optics classically. Cam Norris is now an attending, but he was a first-year resident and had not done awake intubations before. This patient was numbed up with simply a nebulized 4% lidocaine for 10 minutes, and then he got 1 cc of fentanyl, 1 cc of midazolam, and tolerated the procedure really well. I'm going to see if I can run this in little clips so I can talk about the device. So the video laryngoscope is placed. The patients are not bothered by a video laryngoscope when they're numb because there's no, it fits their primary curve. The device has the tube loaded on the back, and you can see this is a single operator technique. Tip is straight, and then it is released, and that solves the primary curve. It has color zones on it, so when you hit green at the vocal cords, you know you're in the right spot. Tip's pulled again, and that brings the snake's head down and easy access. The patient does cough when we enter the endotrachea, the trachea, but because it's a force-free intubation or a low-force intubation and low-force tracheal access, he doesn't mind it much. And then the handle comes off. There's a thumb release on the handle. It comes off, and the tube is inserted over. It's a very quick, very easy, and very efficient way to intubate patients. The prep time is low because there's not a lot of force, so you don't need to do the deep blocks. There's not a lot of deep force. Patients do not like it when you touch their trachea from the outside or the inside. So the less force, the easier on the patients, and the less we need less time to prepare the patient. So what this is single operator, precision intubation, and it's an excellent difficult intubation technique. This is the standard technique at the University of Utah that we're intubating a lot of our awake intubations with. So with that, I'm going to hand it back over to Jamie, and we will take questions at the end, but you can put them in the question window now.
Okay, thanks. Thanks very much. Okay, thank you very much, Sean, for that excellent presentation. I'm going to pick up where Sean left off with the dynamic tracheal access tools. My role is really to go into a bit more detail on the total control introducer that we showed on the last video there. So Pentland Medical have been working with the TCI for just over a year now in the UK market. Already we've seen pretty good uptake in the NHS hospitals and in the private market, and even from that relatively short space of time working with the device, we have seen what is a genuine problem and the need for such a device. So the next few slides, I'll cover what the TCI is, where it fits, the size range available, and how we're positioning it in the UK market. And so on this slide here is really the key clinical point for me, and that is that a good view does not always mean an easy tube delivery. And I know we have a lot of anaesthetists on the webinar tonight, some from the UK and many overseas as well. Anyone using a video laryngoscope will be familiar with this problem. And the TCI is designed for that moment. When the video laryngoscope helps you to visualize the target, the TCI helps you reach it in a controlled way. So it's a dynamic tracheal access tool, not simply another bougie with a handle. The key is active control, where the operator can steer the tip during the attempt, and the aim is to turn that good view that you're getting from your VL into a successful intubation. Okay. Yep, so on this slide, I'm just going to cover some of the key features of the device. Firstly is the articulating tip. This is what gives you the fully dynamic range of movement, allows you to steer up and down to really steer around the natural curves of the airway. That gives you precise movement at the cords, and guides the introducer into the trachea under vision. And the next point here is the depth control markers. So we have a green marker and a red marker close to the tip of the introducer. Once you advance the green marker to the vocal cords, you are at the correct depth. Whereas if you go into the red zone, you've advanced it a bit too far, and we advise you pull it back a little. Notice there is actually a distinguishable pattern between the green and the red zone as well, so even colourblind users can determine the difference. The next part is the flexible shaft. This follows the airway naturally, reducing the risk of any trauma to the airway or to the trachea. And that means you're fighting less against the anatomy. The last point here is the detachable handle. It's a really key feature because it allows you to control the whole of the tracheal access part with one hand while you hold the video laryngoscope in the other hand. And with a simple click of the thumb, you can detach the handle, and the tube, which is normally preloaded on the back, can easily just slide on into the trachea from there. So in summary, TCI offers steerability, depth awareness, flexibility, and simple tube delivery. And I refer back to the video that Sean showed on his last slide there, which kind of showed the TCI in practice. So I'm going to skip through this. So yeah, just in the onto the size range. So there is a comprehensive size range beyond the adult oral size. That's top of the list here. The adult oral size will accommodate endotracheal tubes from 6 millimeters and upwards. We also have a pediatric range. There are 3 sizes in the pediatric range, the smallest of which is for children as young as 2 up to the age of 5. And that will accommodate endotracheal tubes from 4.5 millimeters. The next size is the 6 to 10-year-old, again for 4.5 millimeter tubes. And the last of the pediatric sizes is for 11 to 16-year-olds, and that will do minimum of 6 millimeter tube. Just last on the list here is the DLT variants, the double lumen tube variants. We have 2 sizes available here as well. That will be for 35 to 37 French and 39 to 41 French. And that just gives, it's got a bit of extra length at the back to accommodate the naturally longer double lumen tubes. And it's also worth pointing out the smaller of these, the 35 to 37, will also work on microlaryngeal tubes, or MLTs, commonly used in ENT surgery. Worth pointing out, and I'm going to come on to this in the next slide, is that all of the DLT variants will allow you to perform nasal intubation on adults as well. And also the pediatric sizes will do oral and nasal intubation. So this really shows, the comprehensive size range. It's not just for adults. It gives adults and pediatric, and also in thoracic and ENT settings as well. So yeah, one thing that's generating a lot of interest when I go and do demonstrations around the UK hospitals is the ability to perform nasal intubations, and this is relevant when you're operating in the oral space, and it's still possible to get a good view with your video laryngoscope. The longer configurations, as I mentioned in the last slide, the double lumen tube variants have the required length to go around the back of the nasal passage, and the trigger handle allows you to steer the introducer in the same way. Slightly different technique, but the outcome is the same. It allows you to get the tip through the trachea in the same way. So I'm going to just play this short video now, which demonstrates the nasal intubation on a mannequin.
It's a demonstration of a nasal intubation with the TCI, or the Runnels steerable introducer. So video laryngoscope into the mouth as normal. Obtain a view of the vocal cords. Articulate the tip, and note that it can articulate up and down. So I'm going to put it in straight, and then as I enter the nasal passage, I'll release it so that it rounds the curvature of the nasal passage and enters the posterior pharynx. So into the nose, release the tip, and that just lets it slip around. It appears in my video laryngoscope view. Put it right at the vocal cords. I've solved that primary curve here, and so now I pull the trigger again. That brings the tip down into the trachea. Enter, and then I release the handle. Hear that click. And now the tube slides over and is railroaded into the trachea. And then once I'm in, I just release this and single operator nasal intubation. No McGills, no manipulating the head, no second operator.
Okay, yeah, so that application often surprises people and demonstrates the versatility of the range, showing that it's not just limited to standard oral intubations, and we see that these specialist applications really add value to the range. So how are we positioning the TCI in the UK? Well, it's still relatively new to the UK market. It's only been available for maybe the last year or so. So at this point, we're really promoting it as a difficult airway tool, and that could be for anticipated difficult airways, where access is expected to be a challenge from the outset, but also in rescue situations, when you have a good view on the video laryngoscope, but the tracheal access is proving difficult. In terms of comparisons, where does it compare most closely to? We often say the fiber optic scopes are the only other bit of equipment that will give you that same excellent dynamic range of movement. But fiber optic scopes are expensive. They're often not practical, especially in rescue situations, high pressure situations. And what we tend to see is the outcomes can be quite user dependent, with quite a wide variety of skill levels. The TCI, by contrast, gives hospitals a much more simple access to that range of dynamic movement. It's quick to understand, easy to handle, and what we tend to see is after maybe 2 or 3 uses, clinicians can master their technique quite simply. So in high pressure situations, we see that it's it can have a real good impact having just simple, consistent tools. Now, Sean referred to it in his presentation as well about the DAS guidelines changing at the end of 2025. And what we are seeing when we're going around hospitals in the UK is there's quite a few had already made that leap to VL as standard, but many are now considering how they make that investment. For us, the TCI is a complement to that existing use of VL. It's going to increase the return on investment by turning that good view. It supports the stop after visualization, which is your controlled tracheal access. So the positioning overall is quite simple. The TCI is a next generation airway tool designed for the VL era. So just quickly before we wrap up and go to the Q&A session, Pentland Medical have been working with the device for just over a year now. We understand the need for proper clinical evaluations for any airway equipment, particularly when it's to be used for sort of high pressure situations. Teams need to handle the device and decide where it fits locally within their own airway pathway. So Pentland can support product trials, hands-on training, and departmental demonstrations. You'll see on screen here we have a reference code, Discover TCI, so anyone can contact us to find out about our introductory offers available for the webinar attendees, and this will include product trials and discounted rates on your first order. Our contact details are on screen now. We have our website address, our email address, and the phone number. We will be following up with all webinar registrants regardless to see if you're interested to take up that offer. And just lastly, I know there's many UK-based anaesthetists on the webinar tonight, and I know many of you will be heading to the Guy's Airway Management course next week in London on the 18th and 19th of June. So Pentland Medical will have a stand there. Sean will be joining us, so come along, get a shot of the TCI on our mannequin, and come and have a discussion about how you might implement TCI at your hospital. So yeah, thanks very much everyone for your attention throughout the webinar. We really do appreciate everyone that's joined tonight and everyone that's registered. Please do keep submitting your questions throughout. I can see there's been quite a few already. So I'm going to quickly hand back to Wendy for some brief housekeeping before we move on to the Q&A session.
Okay, great. That's been an amazing presentation. And just a reminder, to access the questions pane, please click on the questions icon at the top right. And we've got, it looks like about 5 minutes left for those questions. So Jamie, take that away.
Sure. Yeah, so I can see one of the questions hits on it's on a really good point here, and that is, what is the difference between the TCI and fiber optic scopes? So, Sean, how do we?
Yeah, I can.
Yeah.
Can you hear me?
Yes.
Just to check. Okay. Yeah, and I can see the questions, so I'll answer them as we go here. The difference between a TCI and a fiber optic scope is the fiber optic scope was not designed to intubate with. It was designed for inspection of the lungs, and then we kind of cross-purposed it for intubation, which is great. Number one is it takes two hands to use a fiber optic scope. The tube has to be preloaded. If you take a look and you decide that the tube is too small, you can pull it off and put a smaller tube on the TCI. The other thing is the TCI shaft is a little bit higher durometer or stiffer, so it carries the tube better. Sometimes with fiber optic bronchoscopes, you can get that kink where the tube is stiffer than the fiber optic bronchoscope, and so it wants to, it overtakes the ability of the fiber optic bronchoscope's shaft to hold it. Now, with a fiber optic bronchoscope, classically not used as just simply a dynamic introducer, the visualization is coming out of the tip. The camera is small. Remember, it has to fit through a fiber optic or a endotracheal tube, and so you don't get that panoramic stable view. It's I call it the doom view. If you guys have kids that play first-person shooter games, I can never win against my nephews because they live in that world where the visual field is fixed and the world is moving around. And so if you think of the normal perspective you have, the world is fixed and your visual field is moving around in that world, and doing switching between those perspectives is hugely mentally taxing. And I think that's why fiber optic bronchoscopes take so long to learn, and you need to be using them a lot. So those are the main differences. This is purpose built to use with a video laryngoscope. Other questions that I see here, I'll try to do the ones that weren't answered by Jamie's. Does it work on specialized tubes? Yes. It's insensitive to tubes. If you get the right diameter TCI, then you can put the right diameter tube over it. We talked about children. Currently, we don't make any below 2 years old, and the reason is once we put the device into a system, we can't control who's using it. And as all of you know, babies are incredibly fragile. We want to have a cohort of people that are familiar with the technique and then work with them to build devices that are safe to use in neonates and infants is where the demand really is. So tracheal trauma is rare. Do you have any evidence demonstrating that the TCI reduces it? We do not. Tracheal trauma, as you said, is very rare. When you have a rare event, what you do is you look upstream of the problem and say, well, what is the thing that might happen upstream that we can measure because it's happening more frequently? But if we can reduce that, then we should reduce trauma. The analogy is airplanes. If an airplane flies, you don't want to have an airplane crash to say, do we reduce airplane crashes? You can look upstream and say, well, if a plane never gets within 1,000 yards of another plane, then if we can lower that, then we should prevent crashes. And so that's a near miss theory. The near misses we're starting to look at are hoarseness and loss of voice. And we will do studies to see if there's a drop in those. And then just general force on tissue. We know that the more force on tissue, the more likely that we're going to have trauma. But it's one of the challenges with airway management is the catastrophic events, fortunately, are rare. And so how do you know if it's reducing catastrophic events? You have to have such huge numbers that that those are very difficult and expensive and long projects to undergo. So we're looking upstream at near misses and seeing if we can lower those. So single operator intubation, as the video shows, means nobody's holding the TCI. In fact, there was somebody holding the tip of it back there. You couldn't see it off camera. One of the anesthesia techs were. You absolutely want to control the catheter as you advance the tube. And so it isn't a pure single operator technique, but it's a skilled operator technique. We often get that in the ED, that they need a technique that they can do completely by themselves. And I remind people that we never intubate by ourselves. Even when I was working in Africa, if I was by myself, that meant what am I going to do with the patient afterwards? But it is a technique that you can have one skilled operator and then quickly have somebody, hold the catheter here as I go in. We do have evidence that it's unpublished, but when you give providers a qualitative signal, that green, and you say, hold the catheter at the cords, keep the green zone in on exchanges, that you get very little tip excursion below the vocal cords. When you ask them to look at numbers, you get a lot of tip excursion. So one of the things we're focused on is making it as simple as possible and as mentally easy as possible to keep that tip from getting down into the carina. It doesn't mean it's impossible, but we do have evidence that if you give them a green zone at a target, and it's on the video laryngoscope screen, and say, hold it at the green zone, it's very easy for humans to do that. And then let me see the others. Will this be incorporated into the national guidelines like DLS guidelines? If I had control over that, yes, it would be incorporated now. I don't have control over that. That will be evidence-based. Those things take time. We do know that dynamic introducers are incorporated in the ASA guidelines as a tool. It's in the form of combined technique or hybrid technique, and that is based on the evidence generated by Mazzanari. And so there is dynamic introducers are part of the American Society of Difficult Airway guidelines. I think they were out in 2023. If you read those, they are recommended to have the ability to have dynamic introducers and the ability to execute a combined or a hybrid technique should be immediately available when approaching difficult airways. And then what's the incidence of unanticipated difficulties in the OR and ED? Are the ER issues more training rather than just equipment? So the huge question, I'll try to answer it in terms of the model I gave you of operator, visualization, and tracheal access equipment. There is, in the US, it is not anesthetists intubating in the EDs and the ICUs. We run a different system here. And so the operators do not have as many intubations in their pocket, and they do fewer. So there is a skill difference, not a talent difference, but simply a matter if you don't do as many. So there is a component where the operator is different. We do know that the operators do better with video laryngoscopes. Absolutely, hands down, we know that. Now think of that system in terms of where is the intubation happening. So the ED and the ICU, those patients have very little margin. Everybody's heart rate is much higher. And so those can be chaotic places to intubate. You may have a team there that doesn't work together every day. And so that's a much more difficult environment to intubate in. So I always put my system when I'm talking to medical students and residents, say the system is operator, tracheal access, and visualization. Visualization determines the tracheal access geometry and the tracheal access tools you should be using. But remember, that system is always being executed in a context. And the context of the ED and the ICU is very different. And that accounts for a great deal of the differences in outcomes there. And then, do we have experience in the military and disaster response? Yes, we do. Actually, the device was used by special forces at what's called their ghost bases, where they are forward deployed. They receive, and this was in Afghanistan, they receive casualties there, stabilize them, and then ship them to Bagram Air Force Base. And it was used there. They would roll the device, take the devices out of the packaging we had, kind of curl them up, and then put them in with their Ranger video laryngoscopes, the GlideScope Ranger. And they worked very well out there. We also, the device has been used in Ukraine. And we have devices actually, Jamie, right now that will be going to Gaza. So I don't care where the devices get used as long as they're helping people. The devices are also used, we donate devices in sub-Saharan Africa currently. So yes, we do have experience there. Now, the one thing I will tell you is intubation in a ventilator is not an ICU. So that was one of the things I learned in Africa. My least favorite thing was when somebody came in and said, we're going to build an ICU around this baby in the PACU area. ICUs in intensive care and critical care require their own supply chains, their own skill sets. You can't just intubate people and then expect them to get better. So that's an aside, I guess. So I'll leave it at that. Generally, the military, I know that the Saudi military, we do sell in Saudi Arabia and the Middle East, and they are looking at the device there as well because it's portable, it's packaged so that it's very portable. Works great in NORA sites because you can have a device in this hand and a video laryngoscope in that hand, and you can go off to the far side of the moon and take care of yourself. Let me see if there's other questions. There's one in German. Christian Temple, I apologize. My son spent a year in Germany, but I do not speak German nor read it. But he did find his favorite word was Verschlimmbesser, and that is somebody that tries to make things better but always makes things worse. So that's about all I can say in German. But I will respond to you. I'll have Google translate it, and then I'll respond to you offline.
Excellent.
And then yes, we do have a distributor in Saudi Arabia, and the Saudi Arabian government is actually a big proponent as they're absolutely becoming the best equipped medical system in the world right now in Saudi Arabia.
Excellent. So I think we'll wrap it up there then, Sean. Thank you everyone again for your attention tonight in tonight's webinar. Yeah, that's all really. I guess we'll hand back over to Wendy now for a little bit of the exit. Everyone who has registered for the webinar tonight will receive the recording as well. So yeah, from myself at Pentland Medical and from Sean, thank you all very much. And we look forward to seeing you, hopefully some of you soon at the Guys Airways show. But yeah, thanks again.
Cheers, and thank you, everybody. Sorry
about that, Dr. Reynolds. And thank you both, Jamie and Dr. Reynolds, for your presentation. An email link of the recording will be sent out to all attendees. On behalf of our speakers, we'd like to thank you for taking the time to join us for our session, and I hope you all enjoy the rest of your day. Thank you.
Thank you.
Thank you.